Welcome to Medicine Handy Point. Today we will discuss uh, history taking from patient presenting with cough. So let's start. So whenever a patient present with cough, first question is to ask about the onset and duration because acute cough, which is less than 3 weeks of duration, is most likely a respiratory tract infection. So duration and onset is important. Any cough between 3 to 8 weeks is subacute, and more than 8 weeks is uh, chronic cough. Now, once we have asked about the onset and duration, next is to ask about the characteristics of the cough. So, what are the characteristics of the cough? We'll ask whether the cough is daily, it is intermittent, or seasonal, like it comes in seasons. Intermittent means patient has some days with the cough and some days off with the cough, and daily means patient has cough daily ongoing on. So then ask about the timing, which is very important. Morning cough is usually chronic bronchitis, while night cough is gastroesophageal reflux disease, asthma, and then left ventricular failure. It causes night cough more. So characteristic has to include the timing of the cough. Then we'll ask the aggravating factors like food and drink aggravate the GERD associated cough. A change in posture like bending forward or lying straight can again aggravate the GERD associated cough. Exposure to dust, smoke, fumes, pollen, and animal can exacerbate extrinsic asthma, which can present as a cough. Cold and exercise can exacerbate asthma, and the patient will present with cough. Now, Um, a status symptom with cough, which comes to our mind first is sputum production. So we ask whether the patient has a productive cough or dry cough. So if the dry cough, there are three DDs for that. Dry cough has three DDs. One, interstitial lung disease. Two, asthma. Three is GERD associated cough. So, if the patient is complaining of just dry cough, these three DD has to be in mind. Sometimes acute viral infection also causes dry cough. On the other hand, if the patient is complaining of clear sputum, it is likely a chronic bronchitis. Then green and yellow sputum acute represent acute infection. Brown false swelling is bronchiectasis, and pink frothy sputum is left ventricular failure. Then we ask about hemoptysis. If hemoptysis is present, it could be acute infection, it could be TB and malignancy. Now, again, if the patient is having chest pain, it's very important. Pleuritic chest pain is characteristic of pneumonia and pulmonary embolism, while chest tightness is due to COPD and asthma, while central chest pain points to what ischemic heart disease and left ventricular failure. Musculoskeletal pleuritic pain can be due to rift fracture due to severe paroxysm of the cough. Now, then we ask about the dyspnea. Sudden onset of dyspnea is pulmonary embolism or acute pulmonary edema or asthma, while subacute dyspnea is asthma, COPD, pneumonia, while chronic progressive dyspnea is COPD and left ventricular failure. If the patient is having orthopnea and PND, so left ventricular failure is likely the cause. Then ask about wheezing. Wheezing represent asthma, COPD, and left ventricular failure. Then we'll ask about other associated symptoms like hoarseness represent acute laryngitis, laryngeal malignancy, or bronchogenic carcinoma spreading to involving left recurrent laryngeal nerve. Ask about upper airway syndrome, which can cause postnasal drip, can cause chronic cough, These conditions include allergic rhinitis, seasonal rhinitis, sinusitis, and acute nasopharyngitis. So, ask about nasal discharge, blockage, facial pain due to sinusitis, sneezing because of allergic rhinitis, repeated clearing of the throat. So, it will help us rule out upper airway syndromes. Then ask about dyspepsia and GERD, and ask about weight loss and fever, which could represent malignancy, and TB. Ask about skin rash and red eye, which is sarcoidosis. Ask about rash or neuropathy with a history of asthma is Church-Strauss syndrome. Then past history should include asking about asthma, COPD, GERD, cardiac condition, history of contact with TB patient, or history of tuberculosis itself. Family history include asthma, allergy, cardiac condition, and family history of TB. Drug history should include NSAID use, ACE inhibitor, and beta blocker use. Drug history should also include drugs which can cause GERD like calcium channel blocker, nitrate, theophylline, and bisphosphonate. These can cause GERD as well, so which can present as a cough. This was all about history taking from a patient with cough. I hope you like the video and please subscribe to the channel.